In this video, we're going to talk about internal carotid artery occlusions intracranially as a cause of acute ischemic stroke and how to recognize an ICA occlusion on a CT angiogram. So we have our source images, we have our thick MIP reconstructions in the axial and coronal planes. If we look at our source images, right away we can see there's significant asymmetry in this patient presenting with an acute stroke with right hemiparesis, aphasia, and left gaze deviation. Once again, we can see radiographically the left gaze deviation, looking at the orbital portion of the source images. And looking at the internal carotid artery on the normal right side, here's where the normal appearance. We see the carotid coming up in the siphon, then up to the above the skull base, to the carotid terminus, into the middle cerebral artery. And then we look on the opposite side, and we do not see any significant contrast to pacification or filling of that internal carotid artery at the skull base or just above it. We don't really see the terminus. We see a little bit of contrast filling in the anterior cerebral arteries here, very little to speak of, just a small amount of contrast in the middle cerebral artery, a little bit more distally from that clot. And now if we look at the axial thick MIP reconstructions, we see a similar picture but better visualized. Again, we see the normal carotid here, no filling of this carotid, which appears to be a clot at the carotid terminus with some reconstitution by collateralization down to the level close to the clot in the middle cerebral artery, but very thready contrasted pacification in the MCA territory. And that small degree of collateral filling or some degree of contrast making it past the clot into the anterior cerebral arteries on both sides, as there's no obvious A1 or initial segment of the anterior cerebral artery on the right side, on the unaffected side. Same thing, same picture that we see here on the coronal reconstructions. If we look down at the skull base, we see the normal right internal carotid artery making its way through the skull base up to its terminus here, and we do not see any contrasted pacification, just an empty bony canal. So one of the things that we need to address now, as with any intracranial occlusion, is to look in the neck and determine, in this case, is this an occlusion of the carotid artery at its terminus intracranially, or is this an internal carotid artery occlusion at its origin in the neck? These are two very different things with very important implications for potential treatment from the endovascular stroke treatment standpoint. So if we look at the anatomy by way of review and look at the course of the internal carotid artery, you have the bifurcation in the neck from the common carotid artery, the external here showing with its branch points soon after the initial origin of the external. The internal carotid artery, once it's formed at the bifurcation, has a straight course or direct course without branching, all the way up to the skull base. Just beyond the skull base are the first opportunities for the blood to flow out at a branch point. You have the ophthalmic artery that comes off here. You have, if there is a posterior communicating artery, a PCOM present, it's going to be here. So just below the terminus is the first point where you have any potential for collateral channels to be present. If there's a clot that covers all of those potential channels here, a large carotid terminus clot, there's really nowhere for the blood to go in the internal carotid artery, so you're not going to have very much filling in the neck. But it's going to have most often a typical appearance that we'll see on this patient's CAT scan angiogram that distinguishes it from an atherosclerotic occlusion of the internal carotid artery right here at its origin. So we'll bring up our CAT scan angiogram portion down in the neck reconstructions and get a view of what's going on in our patient's situation here. So now we're looking down in the neck portion of the same patient's CT angiogram, and this is a thick MIP reconstruction through the left internal carotid artery's origin in the neck. And so once again, to review the anatomy, we're looking at the common carotid artery and the carotid bifurcation in the neck. So that corresponds on the diagram here, common carotid artery, the bifurcation into the branching external here, and the non-branching internal carotid artery all the way up through the skull base. So similar picture here, common, we can see coming down from the bottom of the screen, and then the external, right away you see those multiple branch points, so you can recognize your external, and then you see the non-branching internal carotid artery There is an atherosclerotic plaque with some calcification at the origin of the internal, as is a common location, but the degree of stenosis is well less than 50%, although it's hard to measure the artery distally, because essentially what you see is a slow failure of the contrast to make it up into that artery. There's no hard cutoff. It does not appear that there is an acute occlusion from a ruptured atherosclerotic plaque at the origin, but instead there is a clot downstream, in this case of the carotid terminus, that's preventing the egress of blood out to be able to allow contrast to fully opacify this artery. So it looks like there's a tapered narrowing to the vessel, but that's not actually the anatomy of the vessel. That's a functional consequence of the carotid terminus occlusion. So this is often referred to as a functional internal carotid artery occlusion from the perspective of the cervical portion, the neck portion of the internal carotid artery. But in fact, it's an intracranial carotid artery occlusion distally at or near the terminus, and it's causing a failure of the contrast to make it out. The longer you wait to do your scan, the more contrast opacification you would see. If you have a delayed post-contrast image, you'll see hang-up of contrast and more contrast opacification simply by the passage of time into that artery, and that would be a way of confirming on CT angiography that in fact this is an occlusion intracranially at the terminus, not a cervical internal carotid artery occlusion at its origin. And here we see the patient's catheter angiogram performed for endovascular stroke treatment, and this will illustrate that in fact this is a carotid terminus occlusion, not an occlusion in the neck. Here we have the intracranial views of the common carotid injection. So catheter in the common carotid artery in the neck. We're taking a X-ray movie here of the patient's skull. You can see the subtracted skull here, the orbits, the top of the head here in the AP or forward view straight ahead, and then the lateral or side view here. Here's the skull base of the patient and the orbit here. And this is, again, injecting dye into the common carotid, and so we're opacifying in the normal situation both the external and the internal carotid artery. But what you're going to see here as we move forward in time, we only see branches of the external carotid artery supplying these scalp branches here and branches to the face. And it's very hard to see any flow straight into the brain through the internal carotid artery. If we follow it out farther in time as the contrast is making it farther down the line in the scalp branches, we start to see this shadow here that is the internal carotid artery. So contrast is very slowly making it up towards the site of that occlusion through some side channels, perhaps through an ophthalmic artery that's not covered by the clot, allowing some slow passage of contrast with sufficient time. Same thing in the side view. Contrast opacification of the scalp branches. So far we don't see any clear internal carotid artery, but now we start to see slow passage of contrast opacified blood into the internal carotid artery up to or close to the point of the clot at the carotid terminus. We're going to talk in this video about basilar artery occlusion as a cause of acute stroke and how to identify basilar occlusion on a CT angiogram. So this patient presented with a severe stroke syndrome, including profound alteration of mental status, progression into stupor and coma, as well as quadriparesis, weakness of both arms and both legs, profound abnormalities of extraocular movement, and a impaired pupillary light reflex on both sides. That's a classic description of a severe basilar artery occlusion, ischemic stroke. And on the CAT scan angiogram, here we have our source images, we have our axial thick MIPS, and our coronal thick MIPS. So looking at the source images first, we see coming up from the skull base, both vertebral arteries, we see a more dominant left vert, as is the common pattern. We see a diminutive right vert, and the two come together at the vertebro-basilar junction here. And here's the basilar coming up. We can already see one pretty notable finding before we even get to the level of the occlusion, and that is the degree of contrast opacification here is noticeably lower than you see in the internal carotid artery on both sides as we come up, and we'll see why shortly. So as we come up farther, we see the basilar about midway stop, and we no longer see contrast opacification. Here's the unopacified basilar artery in cross section, and then up at the top of the basilar we see some reconstitution by cross-filling from anterior to posterior by way of the posterior communicating artery, the PCOM. We see this once again even better in our thick MIP reconstructions. We see here at the circular Willis level, we see the opacification of the top of the basilar, and we see opacification of the posterior cerebral arteries on both sides. There's a largely fetal pattern PCA here with some connection at the top of the basilar and a smaller connection to the anterior circulation on the right side. And then below this we see no filling for a stretch of the basilar, and then we see some filling here. So essentially, as we talked about in our video on ICA occlusions, we have contrast coming up, but far less opacification of the proximal vessel by the direct injection compared to the anterior circulation in this case, because of that occlusion at the top of the vessel. There really is nowhere for the contrast to effectively go through a main artery. It can go through basilar perforators into the brainstem, but that's a much higher resistance system, so there's just not as much flow of contrast opacified blood into that vessel below the site of the occlusion. In the case of the basilar, the coronal is a particularly good view on the reconstructions. We see our dominant left vert, our diminutive right vert, and we see the vertebrobasilar junction here. The basilar comes up, and we see that hard stop right there. Again, scroll through the occlusion to make sure that there's no hard turn to the vessel and to confirm that it is indeed an occlusion of the vessel. And you can see a shadow, a ghost here of the vessel filled with clot, preventing the contrast from making it all the way up. And yet again, you see reconstitution distally of the top of the basilar in this particular case by way of cross-filling. And as we've talked about in other videos, once we've identified the site of the large artery occlusion intracranially, we now need to look down in the cervical portion of the CAT scan angiogram, the neck component of the study, to evaluate the anatomy there and find whether there is a clear flight path up to the level of the clot intracranially. Here we have our source images, and we have thick MIP reconstructions in two different planes. Starting with the source images, we're looking here at the skull base. So here we have the foramen magnum. We have the two vertebral arteries passing intracranially. So yet again, we have, as we discussed before, this dominant left vertebral artery. We're going to follow this down from the skull base. And the trick here, the vertebrals can be fairly tortuous in many cases. You need to follow that artery in and out of the plane as we're scrolling up and down, particularly on the thin source images. So here we come, and we're going to have a loop, and we're going to go back down again, and then around, and then you're going to follow the two vertebral arteries here. We're going to focus on the dominant left, but you can see on both sides the vertebral artery is now passing through the transverse foramen of the vertebral body and the cervical vertebral bodies, and we come back down here, and then we see we're now at the level of the common carotid artery on each side. So this is a good way of orienting ourselves. We have the right common, right vertebral, left vertebral, and keep going down. And now we've left the level of the vertebrals passing through that transverse foramen, and we're now in the low neck, passing into the upper chest. We're going to follow this vessel. Again, whenever you get disoriented, you can always come back up, find your vessel in that transverse foramen, and work your way down. Keep your mouse nearby to not lose track. There's a loop in the vessel. Here's where you really need to go up and down. So it comes to another loop, and then here we have the origin of the vertebral artery. There's a little kink here, but we have a clear flight path from the origin. Same thing here. We have our aortic arch. We have our subclavian artery coming up. We have the origin of that vertebral artery, that same kink that we identified here, but again, it's not expected to be something that would make the artery impossible to select. It's just a sharp turn here. Same thing we see in this reconstruction. Again, if you can't find it on the reconstructions down at the level of the great vessels, then you can always start looking higher up where you see that vertebral artery passing along the bony structures through that transverse foramen at each level, and then follow it all the way down, again back and forth, following those loops until you get to the origin of the vert at this left subclavian. Same thing here. You can see multiple levels as this vessel makes a fairly tortuous path down, loop, loop, and your origin, which is a little bit harder to see in this particular reconstruction. So it's good to look at it in multiple planes and get your view of the cervical anatomy of, in this case, the vertebral artery on the way up to this patient's large artery basilar occlusion. So this patient came in with a left MCA syndrome, a right hemiparesis, and aphasia, and a left gaze deviation. So knowing this information, obviously our focus is on the left MCA territory, but we're going to have to remember to cover all of the vessels of the circle of Willis, all the large artery potential occlusions, as there may be more than what we're expecting. So first of all, we have our source images here. We have our reconstructed thick MIP axial image and our reconstructed thick MIP coronal image. So going over, starting with the source images, it's going to be slower to scroll up as these are thin cuts. And first off, we need to window this. So we want to get this in a nice configuration so we can very clearly see the contrast in the arteries silhouetted nicely against the background of the brain and the subarachnoid space. And that's a reasonable window for our purposes. So starting at the base of the skull, start looking at both verts coming up intracranially, forming the basilar, forming the top of the basilar, obviously not our main area of interest, but just to be methodical about it. Both PCAs coming off, so we see intact, normal anatomy without any large artery occlusions. Now, just for the sake of completeness, again, let's start with the opposite side from where we think the occlusion is probably going to be. So let's look at the right internal carotid petrous portion coming up into the siphon, and then the top of the carotid terminus here, the ACA coming across, and the MCA here. And so we see no evidence of a large artery occlusion on the right side. Now let's do the same thing on the left, again starting the base of the skull, petrous portion and left internal carotid coming up, siphon, work our way up to the carotid terminus. We see a T here, we see the ACA coming off, and we see the MCA, and then this is where, as we expect from the clinical syndrome, we see our cutoff. So zooming in, again, we can window this to really put this into relief. And we see some areas of contrast, probably in veins surrounding this area, but there is a hard cutoff right here. Then we see some reconstitution of the MCA territory distally by collateralization. We see the same thing here. On the thick MIPS, it becomes much more obvious. See that hard stop to the left M1 segment, proximal MCA stem, and then reconstitution of the distal branches with a clot occupying this space not filled with contrast. Same thing on the coronals. Again, try to get the window just right for each image. Here is the internal carotid. Zooming in a little bit, there's the ACA, MCA, and a hard stop compared to the opposite side. For reference, carotid terminus, ACA, MCA. See the lenticular striates coming off the M1 segment on this side. See distal MCA, no occlusion, and you see that by contrast here, the hard occlusion in the proximal M1 segment. Okay, we've determined that there's a large artery occlusion in the left MCA. Now we need to look down in the neck and get a sense of the anatomy there to determine our flight path up to the large artery occlusion intracranially. So here we have our source images on the left, and we have our reconstruction of the carotid on the right. So looking at the thick MIP reconstruction, get a good sense of the overall landscape. The common carotid, the carotid bifurcation in the neck, there's a very small area of narrowing there, but nothing too bad. A little bit of narrowing here, but again, there's no significant stenosis and no occlusion of the internal carotid in the neck all the way up to the skull base. And if we want to look on our source images to identify our vessels, first find a section down here in the low neck, high chest region. The top part of the chest, low part of the neck, that corresponds to the common carotid on each side and the vert on each side. So we see our vessels as we come up. We see our carotid bifurcation here on the right. We see our carotid bifurcation here on the left. As we come up, immediately we can see that this vessel is branching, so that must be our external, as the internal carotid doesn't have any branches between the carotid bifurcation in the neck at its origin and the skull base. So we follow our internal up here, again looking at the same thing we looked at on the reconstructions, all the way up to the skull base, and then we can window it so we can better silhouette against bone, and we can see it, we're all the way up to that petrous portion, and we've already tracked it up from there. So going back down, just make sure that we have that connection all the way through, back down, bifurcation, common, tracing the common back to its origin, here, all the way down. Have a little bit of artifact there, but still no evidence of any stenoses, and then the origin at the arch. So there we have a clear flight path up from the aortic arch all the way up to the large artery occlusion in the left M1.